Right. Dr. Lisa Wolf, today we are going to talk about something we've been wanting to talk about for a while. Finally, get to have a conversation about a paper that you recently published. And this one is about pain. However, it's not just about pain, it's about nurses' attitudes and behaviors about pain, which I think is far more interesting than just pain alone.
Yep.
It makes it so much more complex, right?
Yeah.
Because because when we always tell people pain is what the patient tells us it is, do we? Well,
We that's what we tell them.
it's what we tell people all the time. We
Yep.
tell students that, we tell nurses that, we tell ourselves that. I don't know how
Yep.
many times I've told somebody recently, hey, patient says they're 10 out of 10 pain. Let's treat the pain.
Right.
Let's do something. But do all nurses do that? Tell me about the study.
Yeah.
Let's start there.
So so I did this study. I think it's important to mention. So I did this study with Dr. Hannah Noblewolf, who is a medical anthropologist. And so what she kind of adds to the mix is how people culturally accept and express pain, right? So this was like a
Hmm.
super interesting, like added twist to, just my kind of what's the clinical decision making, right? So it's this great collaboration. So it was really good to have her input on this. So we had been talking about this for a while because we're both women. And we know that I think uh we had experiences where we had gone to physicians with complaints of pain and basically just been like brushed off, right?
Uh, 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 Not uncommon for women, right?
Not uncommon for women, for people of color, for people in bigger bodies, for people who don't speak English well. Like I want to know who actually gets treated for their pain. I'm not 100% sure. Oh, white guys. Yeah, that's
White
right.
guys.
So,
Okay, that
but it's kind, and we say this, right? And everybody's like, "Oh, that can't be right," but it is. Oh my God, right? So here, if you'll recall our moral courage study, remember which we talked about a couple of years ago, which I also did with Dr. Noel, and we did it as a mixed method study, which means that we gave people the opportunity to fill out a survey. So this is kind of a knowledge, attitudes, behaviors about pain study. Valid instrument comes out of the UK. We changed it to more American terminology and spelling, and that's about it. And so there's all those kinds of questions as part of the survey, right? So I believe that patients' pain is what they say it is. I believe that people should have their pain medicated, treated immediately, right? Like all the things that we want people to say. And of course, in a survey, people are like, yes, absolutely. I 100% agree with that,
well,
right?
no one's going to be like, oh, they're all full of shit on a survey,
Exactly
right?
right. So I question respectfully, I question the utility of surveys that seek to elicit what we would call pro-social behaviors, right? Behaviors that if you give a specific answer, kind of make you appear to give a shit about anybody else, right? And
Fair
and
enough.
as nurses, I
Because
think that people really believe these things, right? Like, of course I treat my patients well. Of course I address their pain. Why I would never not believe a patient, right? But here's the kind of follow-up piece. So as part of this survey, there are two small case studies, little bitty short case studies, right? So we have two patients, both of whom are like 3 days post-op, and they appear with present with abdominal pain, complaint of abdominal pain, 7 out of 10. One of them is reported as, talking to their friend and, not appearing in any distress. And the other one is presented as like guarding and not saying much, right? So it's kind of like, okay, the patient says they're 7 out of 10
uh,
or 8 out of 10, whatever it was. What do you think they are, right? So the person who was talking with their friends had pain scale. We said, okay, what would your pain scale be for this patient? Um, and it went from like 0 to 7, right? In other words, this guy is totally lying, or
I,
you know, this
it,
person to right?
It's
And then with the other one, it was closer. The range was narrower. It was like, 4 to 7 or 4 to 8, right? But then we asked, what ESI would you assign these to patients? And regardless, they were overwhelmingly assigned as an ESI 3, right?
I
When I'm going to gently remind you that any pain 7 and above should get a 2.
I always forget about that piece.
Yeah.
And
So,
and as I think many do,
right.
because that would make
Or,
everybody it's going to make everybody a two,
well, here's the thing. Like 80% of people present to the emergency department because they have pain.
right? So, like
That's
I
why
said,
they're there.
everyone's a two then? Come on, Dr. Wolf, everyone's not a two. It can't all be twos over seven.
God, you're
Can we
killing
go
me. So what we wanted to really find out, right? So now we have these pieces of information, right? Most people think they're doing a very good job with pain assessment and management, although they'll say, well, we'll get to the qualitative part in a minute. And that, they, faithfully interpret this person's pain and make them a 3, right? So okay, so we have this information. This is why mixed method studies are so important, is because, okay, what do I do with this information? What do I do with this information, right? Do I just carry on because everybody tells me that they are doing it right, or whatever? So, um, so then we interviewed like uh, 10% of the sample. So I think there were like 75 people who filled out the survey, and we interviewed 8 people. So
okay?
about 10% of the survey. And um, something that's probably important to note is that of the 8 people, 7 were white. Um, Everybody was kind of Gen X age, right? So the sample itself was really kind of limited, but these are the people doing triage, right? Because they're the older, more experienced nurses. So then we just kind of asked them, like, how do you assess pain? What are the things you look at when you're trying to contextualize someone's pain? Like, and I was really careful in this interview to not be like, what kind of things make you think this person's full of shit, right? I
Try
was
not
like,
to be
so
too leading.
how do you interpret these behaviors, right? And um, and so what we got was, people started off with like, of course, I believe my patients, except for those guys, right? Like it got to the point where like, well, yeah, I believe everybody, except if they're doing these things, or except if they're saying this, or except, right? So the challenge to reality that we do as triage nurses appears to center on pain specifically, right? So,
Wait,
would you
explain.
challenge someone's blood sugar, right? Somebody
Okay.
came in and said, "Hey, my blood sugar is really high."
Okay.
Would you be like, no, it's not, go sit in the room, right? If somebody came in and said, hey, I've got another UTI, Bactrim worked really well for me. I'm wondering if I could get a prescription for that. Would you even think like, what do you know, right? Like you're just here looking for Bactrim, right? It is a set of questions and challenges that we hold, it appears, only in the context of pain assessment.
I okay. Fair enough. I get that. I understand. The hard part is like you mentioned blood sugar. Yeah, boy, it's something that's super objective. I can stick you, get a little blood, get a number.
Yeah,
If we could only do that for pain, because the reality is pain is so subjective, and
right,
what's a 10 out of 10 for me, maybe a 2 out of 10 for you, like and
right,
that's and
right.
that's
So
where I
here's the
think that's where we
thing.
have the hard part with it
Well,
is
yes and no, right? Because my understanding of pain is not the same as yours, and therefore I cannot judge your pain by my internal scale.
correct. And I I'm assuming we do it all the time.
course we do.
So,
But here's the interesting question is why do we put so much effort in trying to sort out whose pain we believe and whose pain we don't?
right? Just write them
Why
out.
is that like criteria for almost like deservingness? Like you deserve care.
Mm.
If I think I, the triage nurse, decide that your pain puts you at a level where you need to be seen before this other person in pain, right? Like, why do we do that?
I Because we're judgmental people.
I think it goes back to the trying to control behaviors,
Mm.
right? Like we've talked about this a bunch of times where in in the setting of absolute chaos, we kind of like lock in on controlling people's behaviors and like putting people in boxes because that's kind of like the only way that we can make this whole thing work. And so we ask people, why would you think that someone would be untruthful about their pain level? Like, what? Why would they do that? And most people said some variation of they're trying to jump the line.
Mm.
They're trying to get in before their turn, right? Which is kind of interesting to me.
It is kind
Um,
of interesting.
so people did a few things. One is they would just like they would never write down. We were like, okay, so if you don't believe a patient is being truthful about their pain, would you actually write down a different number? Right? If somebody said 10 out of 10, would you write down a different number on your triage
I
form or in your computer?
I
Right?
wouldn't. I wouldn't.
No, but what would you do?
I'd go back and be like, it's a 10.
100%, right?
It's,
But keep this in mind, right? So going back to all the other conversations we've had, what I tell you, right? If I'm the triage nurse, the handoff that I give to you about the veracity of this patient's story is going to determine whether or not you jump in there or
oh,
you think they can wait. And
oh,
that is a very dangerous situation,
gosh, 100%.
right?
100%. Like,
Because if I come in
it's,
and be like, they're a two, right? Like air quotes for those of you in TV land, right? You're going to be like, okay, I got this thing to do over here. Like they can wait. Like this is not so bad.
well, I see it all the time.
Yeah,
I
what do you
see
think's
it all the
going
time.
on with that?
I don't know. Like I think you're right. I mean, I think you're absolutely right that it's about controlling behavior. So, you come in and I'll I'll give you an example. So I'll give you an example is when you start off on the wrong foot at triage, like it's going to be a shitty visit all the way through.
Hmm.
Like if you start off pissing off the triage nurse, like the triage nurse is going immediately back and telling the nurse,
Hmm.
this asshole I just put in room two, X, Y, and Z.
Right.
And and it starts there. When I get patient complaints, I always start with the nurse. Tell me what's going on here. X, Y, Z, blah, blah, blah.
Hmm.
And then I got to try to forget all of that and go in with a clean slate to the patient. And
Right.
and sometimes I say, hey, you know what? The patient's not wrong.
Right. You
Sometimes I'm
are
like,
kind of being
okay,
a jerk about it.
yeah, yeah, sometimes okay, sometimes they're being a jerk. Sometimes they're not. Like just do what they're asking you to do and get past this. Right? Like I remember having arguments with people where I'm like, you can't control that. Just stop.
Right.
Just forget it. You're not going to, like, there's no, we have no right to control this X, Y, or Z.
Right. Yeah, that's the weird thing. Um, I think that what is missing from this conversation, especially now in these very weird times, right? I think I firmly believe that like nurses can fix this, right? But in order to do that, you actually have to understand what your job is. Your job is to relieve suffering, right? And even if somebody is sitting there, like it's one of those things where, 100 guilty people should go free rather than one innocent person be jailed, right? Um, and I really think that it does not harm us in any way to treat people seriously, right? Because those folks will not come back, right? Like, and there's also this thing called pain catastrophizing that I came across. And it essentially it's if I go somewhere, if I seek care for pain, and you minimize my pain and you don't treat my pain, and you tell me I'm stupid for thinking I'm in pain, or it's all in my head, or all the other things that patients, that information that patient gets from us, we we set that patient up to freak out every time they have to seek care for their pain, right? They're not going to believe me. I'm not going to get, right? Now, imagine for those of you who don't live with chronic pain, right? Think about the last time you had, I don't know, really bad stomach ache, really bad menstrual cramps, really bad shoulder pain, back pain, whatever. Um, and and you didn't know how bad it was going to get, and you didn't know if it would ever end, right? And so there's certainly an emotional component to pain because we don't know that it's going to end, right? So there's that fear.
Yeah, boy, if you have anxiety, it will spiral your anxiety.
And if you don't have anxiety, you'll get some,
You'll get some anxiety. That's right.
right? It will be like a bonus thing, right? And so I think throughout these interviews, and in contrast to, um, the survey answers, of course, like we're all very programmed for the right answers. Another thing that I thought was really, really interesting was how people talked about cultural expressions of pain,
Mm.
right? And I feel like they were using the word cultural to avoid using more like racially descriptive terms. So we're just going to go with that, and that's fine. But there was this perception that just like in that horrible Potter and Perry book, which I should about cultural competence about pain, right? Is not that people express pain differently, but that their expression of pain is not as valid,
Mm.
right? In other words, certain cultural groups, women, well, fill in the blank, right? Fill in the blank. Person X is going to yell and scream way more, but it doesn't mean that they're in more pain than I am. It's
Yeah,
wild. It's
yeah,
wild.
yeah. I
And
I'm
and
pretty
kind
sure
of,
I'm pretty
yeah,
sure getting stabbed hurts as much whether you're white, black,
yep, male,
female,
female,
male,
big, small,
big,
all the
small,
things, right?
you know, trans,
Um,
straight. It's all the same.
right. And so I think I'm still kind of mystified by this, right? Why people just spend so much time trying to separate out who I believe and who I don't. Just treat people, right? There's all kinds of ways to treat pain and make people more comfortable. It's not a binary, I'm going to give you Dilaudid or I'm not, right? It's not a binary. There is a huge range of interventions that we can do for a person who's uncomfortable, right?
Absolutely.
Ice, heat, positioning, NSAIDs. You give the ibuprofen Tylenol combo, and you're going to get as good as if you gave them a Percocet, right? There's lots of ways to treat pain that don't involve
Works.
withholding treatment,
Yeah, yeah. You're
right? And
absolutely right.
I think maybe that's it. I think people really think of pain management as a binary. I'm either going to give you some, you know, high octane opioid, or I'm not going to do anything for you, right? And you think about like little
It's
kid comes in to your ER. right? With a broken wrist or a little deformed fracture, are we gonna be like, oh, well, sorry, I can't give you Dilaudid, so we're not gonna do anything? No, we splint them, we ice them, we give them a little ibuprofen, we give them a lollipop, like we do all the things to try to make them feel better. There's a huge range of things we know how to do.
But I think part of that is, I think part of that is one, the assumption or the hope, and it is an assumption. And um, oftentimes patients have tried those things. They've tried the
Mhm.
Tylenol unsuccessfully. They've tried the Motrin unsuccessfully. And the reality is they may or may not have. And oftentimes we don't ask.
Right.
I don't know how
Well,
many
it's
times I've
okay.
seen. Yeah, I don't know how many times I've seen, 10 out of 10 pain with no, have tried this, have tried that, that
Right.
that maybe they tell us in triage and we just skim right past.
Right, but that's so
But that would
important
be good to
because if
know.
I'm the provider and I see, well, this person has been taking ibuprofen for 3 days with no effect, has been taking 600 Q6 hours for 3 days straight with no effect. Well, that's going to change my decision making in the same way that if somebody brings their kid in with 104 fever and you say, what did you do about this? And they go, nothing, I brought them here. Then, okay, we're going to start with some Tylenol,
Yeah, yeah.
right?
So
Don't worry about the autism.
I think
It'll be
that's
fine.
right. I think that's the thing that we assume that they would have, and I think it's an assumption based, and maybe it's just me. I don't want to speak for everybody, but I maybe I make the assumption that they will have tried Tylenol or ibuprofen because I would have tried ibuprofen and
Sure,
Tylenol.
but you're a nurse.
And
You've been a
and the
nurse for
reality
20
is,
years.
I'll never forget when I had such a bad toothache. Oh my God, I was just miserable. And I was rotating ibuprofen and Tylenol like every 4 hours. I
Mhm.
was taking one or the other like for 24 hours with zero relief. And then
Mhm.
that's finally when I went to the doctors. I was like, I really need something for pain. And they were like, and then when I told them what I'd been doing with no
Mhm.
relief, they were like, all right, we'll get you a little something. But I think we make the assumption that people have already done all of that.
Right,
And a lot of times we either don't ask or we don't document.
right. Which is important because, a big part of our jobs, which is getting lost in everything that's happening, right? In the overcrowding, in the risk when you go to your job. Like, we're not seeing people in front of us. We are seeing difficulty, right? If you need something from me that isn't something cool, right? Some cool procedures, some cool stuff, you are bothering me, right? Like, why
Yes.
are you here, right? And I don't think it's quite that bad, but I think that it's really hard to maintain your humanity when you're taking care of 8 patients, right? Like, I think staffing is a big part of this. I think having really new nurses who haven't learned to integrate relational care with tasks, right, is part of this. Um, I think the culture of you shouldn't have bothered to come here. Why didn't you just stay home is there. And I think it's different based on like the configurations of staff that you have, right? It's like, so if you have a good old charge nurse, right? Who can manage all of those needs without like losing her shit, then you're going to learn how to incorporate those two things. But if it's just a question, if I have to get all these people through triage and I can't be bothered to find out what has happened up to this point because I don't have time, then that's going to get conveyed both kind of to the patient, like I don't have time to find out, and also in a very incomplete report that gets passed on to the next nurse.
It's true. I think that's a big piece of it is we just crank them through and we're not, you know, not thinking about it.
And I think pain is like it's one of those really complex things that you need to negotiate, right? Because pain is also a signal. right? It's a symptom. It's coming from somewhere, right? So your patient with intractable abdominal pain who's 70 years old,
Something's
mesenteric artery
something's going on.
ischemia,
Yeah.
right? Triple A, like all of those really high risk things. People, young people with that kind of pain who have connective tissue disorders, also triple A's, right? So like the idea that like young people don't experience pain or um, somehow who the patient is makes them more or less likely to have something serious? Like, yeah, of course. But you have to take each person as an individual. Like, we have this generalized, like, Bayesian analysis. What's the likelihood that this pain in this 25-year-old person is something serious, right? But looking at the person in front of you, like, that analysis is for populations. It's not for the individual in front of you.
Yep. And I think sometimes I think there are some nurses that forget that there's a person in front of them.
Right.
So
Right. Who's left their house, right? It is -5 degrees right now where I am. I know it's terrible. It's the
oh,
worst, right? But anybody who's like managed to get out of bed, who is so in so much pain or in hurting so much that they have to get out of their bed and get to my ER, I'm going to take that pain quite seriously,
for sure.
right? Nobody wants
For
to
sure.
spend a Saturday night in the ER, friends. Like,
Yep.
really, they don't. I certainly
It's true.
don't.
Yeah. It's like the patient didn't come just to annoy you.
Right. So here's where I think we go forward with this, right? Which is, of course, like your next question. Like, so what? What are we going to
Yeah,
do about
then what? Well, before we get to that, like
it? Yeah.
what were some of the other what were some give me some of the examples of some of the questions you asked the during the interviews, or give me some examples of like questions where you're like, hmm, okay.
Yeah.
Where you were like, okay, were you seeing a big difference between what people put on paper when they were just checking the box versus
Yeah.
somebody who's sitting in front of you?
Yeah. Hang on one sec. Um, I was really amazed, not really, but a little bit amazed, that people were very committed to the idea that certain people underestimated their pain, right? So the questions that we asked people, we asked them, how do you decide when to assess a patient's pain level, right? Like, in other words, in the triage encounter, do you start with that or do you like work your way to that? How do people measure pain? Everybody used the same one
Out of
out of
10.
10 scale. I said, did you have any training on how to assess pain? They're like, no, they showed us the 1 to 10 scale. Um, we asked them, in what ways do you try to confirm or challenge a patient's report of pain? Right? So do you rely on vital signs? Do you rely on behaviors? Do you rely on what the patient tells you? Um,
Do uh, if I had how many times I've said, maybe the reason they're tachycardic is because they are in pain.
right. Crazy,
That
right?
validation with vital signs.
Right. However, yes. However, vital signs, one of the questions on the survey was vital signs don't always tell whether or not a person is in pain. And people were like, oh, yes, 100%. I agree. You can't rely on vital signs to know whether or not a patient is in pain. And every single one of them were like, well, I always look at their vital signs.
Hmm.
Because guess what? If you're in 10 out of 10 pain and on a beta blocker,
Yeah,
you might not be tachycardic.
good
You
point.
might not be hypertensive,
Yeah,
right?
it's a good
Or
point.
you may be having a flare of your chronic pain. You may be having acute on chronic pain, and you're just so used to it, right? We also asked, what do you do when a patient's report of pain doesn't align with your perception?
And on paper, I'm sure they were like, well, then we go with what the patient says.
Yeah, well, and then we asked how to use pain to inform a triage decision. These are the interview questions, right? And so this is a technique of presenting findings that I learned how to do, oh my gosh, almost 10 years ago. and you present, and it's a table in the paper, right? So here's your quantitative findings, like what did we find in the survey? What did we find in the qualitative interviews about the same thing? And then how do those things either diverge or converge, right? Um, and so, for example, that 88% of people agreed that pain expression is influenced by culture. Okay. And in the qualitative findings, however, people are like, people who act out are it's a cultural thing. It's a group mentality where, you can't just have pain. We have to be like writhing all over the place.
Hmm.
So people did, in fact, agree that pain expression is influenced by culture, but not in the way that you would think, right? It would be like, oh, that's a little different, right? Like I can still manage that. But they were like, no, they're just totally making it up, right? Essentially, right? Like, why do we have to be so, whatever? Now, what's important here is that, so what comes out of this really is that although the overwhelming agreement with the statement would suggest better pain assessment skill, it actually seems to suggest that they understood cultural expression to mean not really in pain. Thank you, Potter and Perry, right?
Yeah,
All the nurses, just about all the nurses who were interviewed are about our age. And so they're of the rub dirt on it, like don't cry, rub some dirt on it generation, right?
you'll be
So I
fine.
think that also really informs how we think about pain. Like, what are you making a big deal out of this? Like, I was never allowed to make a big deal out of this. Friends, go and get some fucking therapy, okay? So that we can stop projecting our own trauma onto our patients, right? Let's get some therapy about this.
That's funny.
Um, right? So, another thing that in the survey, 90% of people agreed with the statement that patients should be totally honest about their pain, and 71% disagreed with the statement that patients should be stoic, right? So we're definitely, everybody's thinking like, you should absolutely tell me about your pain, right?
Like,
But then in the
but don't be a
interview,
baby.
what?
But don't be a baby.
Right, don't be a baby. But people are like, I like to believe my patients, but when they say things like, they request specific medications, like I put it in the note, right? Like, oh, hey, this is what really works well for my pain. Oh, God forbid, right? That you should get the thing that works. Like, let's try all these other things that aren't going to work until we finally like land on the thing that works,
Always,
right?
always.
And what they say is they put it in quotes in the note, right? And so a lot of people, like one person said, I was always told four is a great number.
Four is a great number.
Four is a great number for pain. Like, why do you want to get to zero, right? Or why do you want to get to one? Because four is fine, right?
What?
Um,
You're like,
it's not.
I'm a four when I get up in the morning. What are you talking about?
Right. And here's kind of the crazy thing. So some people worked in areas where hospitals were kind of clustered, like they were maybe 5 or 6 miles apart from each other. And while people in the survey, and mind you, we surveyed the interview people are a subset of the survey people, right? Um, they said that patients with chronic pain may need larger doses of analgesia. Um, and they also disagreed with the statement that patients should not receive pain medicine in the ED for chronic conditions. So basically, we're all like, okay, we understand chronic pain, like that people may need higher doses of medication. But what they told us in the interviews was that, well, the doctors who work at different hospitals, they look at the chart, they're like, oh no, I saw this patient like last week. We can't do anything for them, so we're not going to do anything for them, right? And so the idea that what comes out of this really is this like theoretical understanding of how chronic pain works and an absolute suspicion of patient motives when they seek treatment for that chronic pain, right? So like we can't have it both ways. We can't have both ways.
And we try to, and we try to, we try to have it both ways. And God, yeah, I mean, if you're a chronic pain sufferer, like you're gonna get shit. Like
Right,
you're,
right. A lot of we talk about like documenting pain scores, everybody maintains that they would not change the number, but they would document kind of around the score, right? Um, and I think that because it is so subjective and because people's behaviors around pain are very different, right? Depending on a huge number of things. Um, People in really severe pain may just not do anything, right? They may just sit there. They may not make any noise. They may not move much, or they could like yell and scream, right? It depends. You get to a point where being really quiet is no longer an option, right?
yeah. And I think yeah, it's always you fear the person that's coming in screaming, yelling in pain, but yes, yet you also fear the quietly suffering child, for instance.
Right. Oh, quiet children is like
Yeah,
no
where you're
good.
like, oh,
No good. Um, I think that people also spoke a bit about the quiet people as not believing their pain either, right? So like basically they were like, hey, if there's like an old white farmer guy who tells me his pain is a 4, I don't believe him, right? But I'm like, well, if you don't believe the person who's telling you about their pain and you don't believe the person who's not telling you about their pain,
who
like,
do you believe?
what do you believe about pain?
Who do you believe that there is a very small subset of people that can accurately and effectively score their pain?
Yeah, it's so weird. Like, so what I sort of have found a little bit more is that there are a couple of, I think, better ways to ask people about their pain, and that is in terms of function, right? So how is your pain with regard to your ability to do your ADLs, to go to work, to take care of your children, right? Because people gut it out a lot, right? And
All,
they can say, well,
all the time.
I can, you know, I can't go to work today, right? Because it's all I can think about, right? Like this pain is all that I can think about. I cannot focus on anything else. Um, when it gets to the point where people like especially with things like orthopedic pain, back pain, like I can't get out of bed, I can't brush my teeth, I can't do any of these
Yeah,
things.
I mean, if I had a nickel for every nurse that I've worked with back pain, like all of them. Okay,
Right,
maybe not all of them, but yeah, many.
right,
But when they're like, I couldn't get out of bed, I was in so much pain. I was like, ugh.
right, exactly. And so I think that's actually a better way to ask people about their pain rather than a 1 to 10 because we don't believe people, right? Now, that being said, sometimes the answer to I'm really in a lot of pain, like I'm unable to do anything. Well, you got here, didn't you? Right? Like, come on, what is that? What is that? Stop it.
Yeah,
Don't be a terrible person,
yeah,
right? Like our job is to help people. It is not to gaslight them. It is not to deny them care because we're having a bad day, right? Like, so a lot of this, I think, requires like it's almost less uh it's it's less education and more accountability in a way, right? Like we can educate people about, I mean, a 1 to 10 pain scale is what? It's a reference point, right? For me, I'm just like, okay, where are we starting? Let's see if we can get that down, right? Like I'm
yeah,
not going to question the validity of any particular number
yeah,
because all I want to do is make it go down,
yeah,
right? I think understanding and this is where patho I gotta beat the patho drum yet again, right? Is that if you understand what's causing pain, it becomes a lot more serious. in your head. Like you're better able to make an acuity decision. Because if somebody is complaining of squeezing, aching pain, that is ischemia. They, whether it's in their chest or their leg or their, whatever, right? Electric pain shooting down their arm or leg is nerve pain, right? Like if you if those two sentences were a surprise to anybody out there in TV land, pick up a patho book, right? Go look it up because when you can do a good pain assessment, when you can ask somebody like, tell me how all the P, Q, R, S, T, X, Y, Z, like it's, I don't know, 50 letters now, but essentially, where is it? What does it feel like? When did it start? More importantly, what makes it better or worse? Is this positional? Is this regardless of position? Is this, burning, aching, stabbing, squeezing, electric? You get a much better sense of what's causing that pain, and it allows you to make a clinical decision, not a moral judgment.
Yeah, you're 110% right. Like it's if you don't understand it, how could you treat it?
Right. Or you can make a good clinical, like when we think about triage, and this is what I want people to really remember, hold close to your heart. A triage acuity score is a summative clinical judgment. You are making a decision about whether a patient is stable or unstable. And this is why you need vital signs, and this is why you need to actually talk to people. This is not something that you can eyeball across a room. I would gently offer, except if the patient is coding, right?
Yeah,
Right? If you
yeah,
and so the comprehensiveness of that decision, because this decision dictates trajectory through the
everywhere,
emergency department visit.
everywhere.
It it tells the next person who gets this patient how worried they should be. And if you are just feeling pissy and don't feel like anybody deserves care today, like, please just go home. Please just go
Yeah.
home.
I mean, it truly colors everything else that happens, right? It
Right?
colors how serious the nurse is looking after the patient takes it. It colors how fast the doc's going to get up off the chair to go see the patient. It colors everything,
Right.
and and really sets the stage. Like I don't know how many times I've seen people be like, "Oh, yeah," they're complaining about the patient before they've even, they're complaining about the patient before anyone even gets a chance to see them. It's like, don't tell me all of that. I don't want to hear it. Like, just let me go in. Let me have a clean slate. Let me just go in there, have a clean slate. Maybe they didn't like you, but maybe they're gonna like me just fine.
Right.
And one of the things I think I'm pretty good at, of course, I think I'm pretty good at. Everyone probably thinks they're pretty good at. I think I'm pretty good at giving people a clean slate. There's very few times I've went in like already angry with the patient. And those times are when, when things get violent or physical, then it's like I'm already here, right? Like instead of, but oftentimes, you're like, I feel like I can go in and kind of go in and give them a clean slate, be like, look, tell me what's going on. Um, and not be too colored by what I've heard already. So, but it colors everything.
Right. And this is huge. I'm going to offer, just because you're in Texas, right? The number of women having reproductive issues, right? Miscarriages, whatever, whose pain is not treated, is not understood for like the process that is happening, right? And and they get sent home and they die, right? Like, but you can apply that to a whole bunch of other populations, right? If we dismiss people's pain, if we deny them care or we delay care, we are not doing our jobs, right? Again, we do not sit in judgment. We just do our jobs. And your job, my job, is not to decide who is worthy of care. And that's really hard to remember when you're exhausted and burnt out. But that has two pieces, right? Like that is a systemic problem. And that's why all the nurses in New York are on strike. And that's why nurses in a whole bunch of other places are on strike because we know that we are not doing our job well. We can't do our job well if we don't have the structural support, right? So I don't want to make this 100% like, oh, nurses are bad people. I'm saying the conditions under which we work make it really difficult to do anything but cut to like our a preliminary decision, and that's really dangerous.
Yeah. Yeah. It's and it I mean, I don't know how many times you just got to say it. Like if you're in survival mode for your 12-hour shift and feel like you're getting your teeth kicked in every which way, you can't focus on trying to, provide good customer service too.
Right.
So,
It's not even just, I mean, yes, customer service, sure, like the Press Ganey, the one survey to rule them all. But the it's relational care. Like people, you have to remember that term therapeutic rapport. Remember that from like your first semester of nursing school? It's a thing, friends. And when you have a good rapport with your patient and they trust you, they will tell you stuff and you can help them better. And ultimately, it's less time for everybody, right?
yep,
Once you get the real story, you can start working on it. But if people are afraid to tell you things, then you're never going to get to like the bottom of it. And it's delayed care, prolonged care, same person in your bed, the whole goddamn shift. And this way you can just kind of get people through.
yeah. And I think one of the things I think that I see so many times is, and I've said this a million times, is for as good as you are, for as good as you are as a nurse, for as good as you think you are with your BS detector, that you can detect BS, and when you think you can detect when people are lying, you think you can detect when people are being honest, not being honest. For as good as you think you are at that, I promise you, your patients are probably better. And and they're probably better because for you, it's about, managing your work life. But for them, the ability to read people could be a matter of survival.
Hmm.
And and truly, like people who are annoying know they're annoying, right? Like people who are a pain in the ass, they know they're a pain in the ass. They know that. But they also need to be able to read when someone's getting ready to punch them in the mouth, right?
Hmm.
So for them, that ability to read people is becomes survival. And if they're that good, they know if you don't give a shit. They
Right.
know if you don't care. They know if you don't believe them. You're not hard to read. And if your patients come in and they say they have 10 out of 10 pain, and you're like, oh, no, okay. All right, great. 10 out of 10. Gotcha. Let me write that down. Um, they're just going to get angry if they, if they're at a 10 out of 10 and they see that you are absolutely not buying it, absolutely minimizing their pain. They're going to, it just builds their anger.
Right. And wouldn't you if you went to a provider and were like, hey, I'm really uncomfortable, and they're like, no, you're not.
Yeah,
Like that would make you really upset. Would make you,
100%.
right? And we really want to think back to all the other conversations that we've had. Who do we not believe? Who are we questioning? Who do we think is just there for some nefarious purpose, unrelated, right? Um, and and I think that what I hope comes out of this that um, is that we start really thinking about why am I working under conditions that do not allow me to do a good assessment, right? Why am I being asked to essentially run people through some kind of moral sieve as to who deserves care and who doesn't, right? Like we take care of everybody and we take care of them in the way that they need to be taken care of, not in the way that we think they deserve to be taken care of, unless we think everybody deserves to be taken care of, right? This is not like some Calvinistic exercise where some people get better care than others in
Yeah.
the ER, right? Like there's boutique medicine, there's all kinds of reasons, but
Yeah.
the ED is the great equalizer.
One of the things I see it, where I see people absolutely minimizing pain, absolutely minimizing symptoms is anyone who's got any kind of psych history
Oh, of course,
or
sure.
or substance abuse history.
Yep,
Like like or if you look like this, I don't know how to I don't know how to say this without, you know, like if you look like you have drug use history, right? And
right,
and you get judged to be that, whether that's true or not.
right,
Um, yeah,
right. That
those people get
first
minimized.
impression bias, like putting people in a box, premature closure, like all the cognitive things,
All the
all
stuff
the
we've talked
cognitive
about over
errors.
and over and over, right?
Mhm.
Yeah.
Right. We tend to rely on heuristics, right, when we have not a lot of information. And this is
Heuristics.
well
What
known.
is
Heuristics is like the shortcut. It's a mental shortcut,
mm,
right? So I see this, I think that, right? I see a skinny, blonde, college age, hyperventilating girl, and I immediately go anxiety rather than PE, DKA, maybe anxiety, maybe all three, right? Like you can be anxious and have other stuff, right? It's not binary, like medical thing or anxiety. You can have both. Why not both?
yep.
Um, yeah. So it's the mental shortcut, and this is sort of where we have talked about the nurses who think that they know everything, like just by looking at somebody and friends and neighbors. That's not true.
Yep.
You don't.
What's the
Um,
next step for the study? What
well, actually, what we're trying to do is we're trying to repeat the study, but with patients. And we're actually, in other words, we want to interview patients who've presented to the emergency department within the last like 3 months about their experiences with pain assessment and management.
that's going to
Because
be
I want to
interesting.
hear this from the other side.
That's going to be interesting.
Well, if I can get some people, I mean, I'm actually having a hard time recruiting. So if anybody knows, anybody out there,
How do you recruit for something like that? Do you
well,
put a
social
flyer in a
media
hospital and
helps.
say,
No, I absolutely cannot go
okay,
to a hospital and be like, "Hi, I'd like to talk to how your patients feel about their pain management." Um, so I am trying to like spread the word everywhere. So,
well,
yeah,
let's let's I mean, do you have a flyer for it, or do you have
yeah.
a like a I haven't seen that. Like,
Oh, I'll
how do
send
we
it to you.
share that?
Sure, I'll send it to you, and you can like
Send it to
put
me on
it.
send it to me on Facebook and I'll share it out.
Yeah, yeah. Okay, I will totally do that. But that I think is really important to understand how. So the questions that we want to ask those patients is essentially like the survey. Like we have a brief survey, and it's kind of like, have you been? Was it for acute or chronic pain? Did you feel like you were taken seriously about your pain? How do you feel the provider treated your pain? Were you seen within how many, how long did it take to be seen? How long did it take to be medicated? Did you feel like you have to perform pain in order to get help or not?
Oh, how interesting is that going to be?
It is so interesting, but nobody wants to do it. I'm sad. So yeah, so I'll send it to you, and if we can have anybody who wants to,
Yeah, we'll put it in the show notes for the this episode.
sure, that'd
Um,
be awesome.
but I'll also share it on Facebook.
Cool. Perfect,
So,
perfect. Yeah, I'll send it to you
uh,
just a little bit.
Very interesting. Pain from the other
And
side
it
of the
is also
chair.
IRB approved.
Nice.
It's approved by IRB.
Pain from the other side of the chair. I think that's going to be interesting.
Yes. Yeah. I think this is like super, super, super important.
Do you think, yeah, you mentioned that a lot of Gen Xers, do you think it would be different if it was a different age group that you were?
I'm really interested to find out. I feel like in the way that a lot of younger folks kind of just don't have as much baggage,
Maybe, yeah.
you know? I feel like they do a better job. They're less judgmental.
Hmm. Yeah, I don't know. I'm not sure how I feel about that.
Yeah, I'm not really sure. That's why I'm really interested to find out.
Yeah, be interesting. We'll share the paper if you listen to this episode in the next 30 days or so. Probably less than 30 days now, but
Mhm.
if you are listening to this episode in the first couple of weeks that it comes out, you will have access to the paper.
Right,
We'll put a link to the paper and share it in the show notes so you can take a look at the paper and and then kind of form your own opinions. So
right. Yeah, I mean, I think really shifting to a more disability-based questioning about pain, how has this impeded your life rather than like give me a number.
I like that.
Yeah. Well, it's also less like judgmental.
Yeah. So
It's less judgmental. So that's kind of where we're going with this.
very cool. What an interesting study.
Yeah,
Yeah.
I think so. I think it's always really interesting to figure out how people think about their decision making.
What I think is interesting is the variance between what we say on paper in a perfect world and what happens when the rubber meets the road, right? Because you can learn everything. You learn everything in class. You learn all the right ways to do things. But when the rubber meets the road, what are you really doing?
Right.
I
Right.
think
I
that's
think,
interesting.
yeah. And so maybe it's time to think about like, if I say this on paper, right? It's hard to think of yourself as like
Yeah.
having like a cognitive error.
Yeah.
I just think the more we know about how people make decisions, the better. Like a lot of it is just uncovering, right? Like, oh, do I think about it that way? Let me think some more. Now I'm thinking about it, right? There's some metacognition happening. I'm thinking about how I'm thinking about this, and now I can start making some changes.
Absolutely. Absolutely. I love it.
Cool. All right. Well, super great.
Good talk.
Yeah, good talk.
Thanks for listening to the How Not to Kill Your Patient podcast. Now get out there and don't kill anyone.